Thank you, Peter. So I'd like to thank Dr. Tewari, in particular Prasanna, for helping with the logistics, for inviting me, and for giving me the opportunity to speak with you today. What I'm going to do is I'm going to cover 4 areas that really are of clinical interest, many of which you'll hear in more detail later on in the meeting by experts in those particular areas. So what I will really do is give you more of a synthesis of information and try to give you some interpretation of what it may mean. The first area we'll talk about is PSA as a screening tool. Then we'll talk about surveillance, in whom might it be appropriate. Then we'll talk a little bit about how we identify aggressive prostate cancer based purely on clinical parameters. The genetics I'll leave to the scientists. We're not quite there, but we're getting close. And then finally, I'll finish with the management in the post-operative setting of a patient with a rising PSA. So those are the 4 things I thought I would cover. In a prostate cancer update, you have to pick some things. There's just so much to talk about. I always like to start the talks with just a brief story to set the stage. And this story obviously is fictitious, but it takes place with the conversation that's occurring between God and St. Peter, and the conversation goes something like this. You know, it's been too easy to get in here lately. I think when people come up for judgment, they need to give a story about their last day that's extremely convincing and compelling. So down on earth, there is a gentleman at work. It's noon, he's pacing back and forth, and he's saying to himself, gee, I know my wife is being unfaithful, and I know I've seen signs of it, and he says, I just can't stand it anymore. He bursts out of the office, he goes home, he walks into his house, and there's his wife sitting on the couch in the living room. And he says, do you mind if I just, I'm going to go into the bedroom for a minute. And he walks in the bedroom and he looks around and there's nothing there. He comes to his senses and his anxiety starts to get allayed. And he says, I don't know what I was thinking. I'm going to go out and apologize to my wife and go back to work. And as he's walking out of the bedroom, he looks out the window, which is shut, and he sees a man hanging from the ledge, his fingertips. He says, I knew it. He throws the window open, he pounces on this man's fingers, and is on the 3rd story, and the man falls back, but fortunately lands in a dumpster. They're doing some construction on the house, in which is lots of packing material, so he's completely unharmed. This enrages the gentleman even more. He runs into the kitchen. They have a refrigerator on wheels, and he pulls it out, and he's pulling it and pulling it. He gets it to the window, he tips it over, and just as it's getting ready to fall over onto this gentleman in the dumpster, he has some chest pain, has a heart attack, falls on top of it, and the 2 of them go down, refrigerator and this gentleman. So the first person to walk up to St. Peter is the gentleman who was hanging from the ledge, and he asks for the story, and he says, you're not going to believe this, but, I'm a rock climber, and I was scaling, this building, and a man threw a window open and started yelling at me, pounded on my fingers till I let go, and I fell backwards 3 stories. Fortunately, was unharmed. I fell into a dumpster with all this soft material. The next thing I see is a refrigerator and the gentleman coming down after me, and that's the last thing I remember. St. Peter looks at him and says, you can come in. Coming up right behind him is the gentleman who was enraged and tells his story. And St. Peter takes compassion on him and he says, okay, he says, I'm going to let you in too. Now, usually when deaths occur sequentially, the people come in sequentially, and a 3rd person comes right after this gentleman. St. Peter's kind of scratching his head, wondering, where this 3rd person could be coming from. And he asks him for the story, and he says, you're never going to believe this. But the last thing I remember is that I was hiding half-dressed in a refrigerator, and then... All right, so there you go. That's the element of surprise. 3 in a row, and there's always something more you can think about. All right, let's see if we can get this to advance. Let's try enter. There we go. So the first topic that we're going to talk about is PSA and the detection of prostate cancer. As you'll hear in a little bit from Dr. Schroeder, and I'm sure you'll hear throughout the meeting, there are several studies that have been published now addressing this particular question. And by no fault of anyone, no study is perfect, right? And it depends upon the time and the practice. One issue that has been brought up about the studies, particularly the US-based study, is that about half the men, 44%, underwent some type of PSA testing before they actually were randomized and entered the trial. This number was a lot smaller in the Swedish subset of the European study, being 3%. What does that do? I kind of make the analogy, to just had Easter, little kids looking for Easter eggs. And, if you're going to hide 50 Easter eggs and you have the kids find them, and there's 5 kids, they have a good chance of finding at least one. And if the eggs are prostate cancer, that's kind of how you think about it. Now, if you take 50 of those eggs and you do PSA screening and take out a lot of the people who would have been diagnosed ahead of time, it's like taking the 50 Easter eggs, cutting it down to 20, and you tell the 5 kids, go find one. Their chances are much less of finding one. And that's what pre-randomization PSA testing does, is it takes out of the population the prostate cancers that were probably the most aggressive, that may or may not have a benefit from screening, but you'll never know. It just dilutes the pool and it reduces power. And that was one issue with the PLCO study. The other issue, the big one, is contamination. And what's contamination? That's when somebody who's randomized to the arm where they're just getting no PSA, just annual exam, go ahead and get a PSA, either on their own, by their own intention, or inadvertently, primary care orders it, or they go to a prostate cancer screening, it's obtained. Then they have this information, and they can choose to act on it or not. When you do that, you dilute out the possibility that you might actually see an effect of PSA because people in the control arm now are getting it at some proportion compared to the people in the arm that were supposed to get it. Now, this number reached 52% by the 6th year in the U.S. study. That means about half the guys were getting it, and the study was powered for about 38%. So again, a chance to underpower the study, to make it less likely to show a benefit even if one exists. This number was estimated in the European study, and Dr. Schroeder can shed more light on it, at a much lower number, about 6%. The other issue is that there's something called non-attendance, and that is in the arm, the PLCO arm, of men's randomized to get PSA, 15% didn't comply and didn't get it. So what you have is a study in which half the men got PSA versus 85%, and that's what you're really comparing. So we all know these issues. They've been brought up many times. I want to take a slightly different bent now on these issues. The median age in the studies are shown below, and I think age is extremely important because while age is not a surrogate for health, exactly, there are some young men who are not healthy, there are older men that are healthy, it's a good approximation. The younger you are, the more likely you are to be less likely to have comorbidities that might affect your life expectancy, and ability to see a difference in a screening test that may not affect your life for 10 or 15 years. So here are the results of those studies. As we know, the U.S. study did not show a benefit. The hazard ratio actually was a little over 1. Not significant. The European study did show a 20% reduction in cancer death, p-value of 0.04 at the time it was first reported. And the Swedish study, which is a subset of the European study with the youngest men, age 56, did show a significant benefit, 44% reduction. The numbers needed to treat, actually the additional number needed to treat, that's the way you have to think about it, because you do need to treat some people with just rectal exam each year. And what you're looking at is how many additional people do you need to treat with rectal exam plus PSA. It was 48 in the European study and 12 in the Swedish study. And the 12 is remarkable in that it had longer follow-up. It was at a 14-year estimate. You'd expect the number needed to treat to get better if the screening test works as time goes by. And the Swedish study had the youngest and presumably the healthier men compared to the whole European contingent. Now, this is the Swedish study. I've put a vertical line there. It's 6 years. This is the death from prostate cancer curve. The blue line is the screening group. The red line is the group that did not get PSA. And what you see is that just between 6 and 7 years, these curves start to split. Now, this is not something I appreciated until recently, because there's a trend here I'm going to show you across these curves. I would have never thought that only 6 to 7 years after randomization would you start to see a benefit from screening with PSA. It's just too soon. First of all, in that 6 to 7 years, you've got to diagnose the cancer, treat it, and then see some benefit from your treatment. That says to me that there have to be some cancers picked up that are being picked up at a time that they're still curable. And this is pretty interesting information here. I had only appreciated this recently, that the split in the curves is fairly early. Because we talk about 10 to 15-year life expectancies, for screening, not 7 years. Now, of course, it's just starting to split at that point. It's only a 2%, not even, it's a minuscule difference. But it does talk about, when you think about a population, about what your benchmark might be for longevity if you're thinking about when PSA might be useful. Here's the European study. I put a hashed line at 10 years. The curves there, interestingly, start to open just after 7 years as well, if you look at it. But they don't really start opening a little more significantly. That 10-year dotted line has the same difference in the curves as the Swedish study has at 7 years. That's why I put the line there to try to give you the relative, or the absolute benefit. And it wouldn't surprise me that this absolute benefit is 3 years later in a group of men who are older, 60.3 on average, not 56, therefore probably less healthy, may have competing risks. So these two curves kind of make sense to me. And then here we had the privilege of really looking at the PLCO data with Dr. Andriol and Dr. Crawford and doing a post-randomization analysis, which I'll say in the first sentence is hypothesis generating. It's not definitive, but it's interesting. I'll show you how it actually fits in with what I just said. We looked at men stratified by their comorbidity at randomization. The comorbidity information that was assessed in the PLCO study was not sufficient to make a validated metric like Charlson, for example. But what we did instead was we looked at people who were in very good health, and their median age was 61, and those are people who just had arthritis or osteoporosis reported on a questionnaire. So they had no cardiovascular risk factors, they had no risk factors for second cancers, which is the bottom of the slide, which we used as, we called that the significant comorbidity group. Now look in that significant comorbidity group, you've got MI, CHF, diabetes, but then you got hypertension. You've also got inflammatory bowel disease, but then you got colonic polyps. So, this definition runs a gamut. But what we really tried to do, because there was no way to make a validated metric, was get people who are extremely healthy, who had nothing that was going to limit their life expectancy that we knew of, like arthritis and osteoporosis, versus those who have something that may limit their life expectancy. And what we found when we did this, out to 10 years, 164 cancer deaths, is that in fact in the very healthy subset, which made up about a third of all the men, there was a significant reduction in cancer death, the same hazard ratio that you got in the Swedish study, and the additional number needed to treat was very small, only 5 at 10 years. And so it hints at the fact that perhaps the way PSA screening should be thought of is selectively towards men who are either young or in good health. And that can go either way. You can't just use an age cutoff. It's too simple, right? There are guys in their 70s who are in pristine health, and there are guys in their 50s who are not. You have to actually use a little bit of thinking in terms of morbidity. And then the last thing is that thing about the 6 or 7 year split in the younger, healthier people is quite remarkable. For people with significant comorbidity, about 2/3 of the patients, a benefit was not seen. However, there was a trend in the opposite direction towards more cancer death. Not significant, but interesting, 20 additional deaths. How can that be? Well, actually, this is how it can be. The way it could be is that if you have people who have comorbidity, Dr. Carroll and others have shown that they are treated less aggressively. If you screen people, many have shown, you'll pick them up earlier, lower intermediate risk disease. So put the two together, less aggressive treatment, earlier detection, and a man with comorbidity whose life expectancy may be more than 7 or 8 years. That could explain why there's a trend towards more death in what we called significant comorbidity, because not all comorbidities are created equal, and some of those comorbidities may actually have been overestimated, and people were treated less aggressively, and maybe lost the benefit, suggesting that there may be more of a pool of people who benefited in this study than we think. These are the two curves. The left is minimal comorbidity, the right is significant comorbidity. Again, you can see both in the left and the right-hand curve that they start to split in the 6 to 7 year time frame, saying that in the healthiest men on the left, you don't need a whole lot of time to start to see a benefit. But do look at the axis. Dr. Albertson, I'm sure, will comment on this. That's 0.1, 0.2, 0.3% cancer-specific mortality. So, that separation in those curves are on the order of 0.1% when you get out, or 0.2% when you get out to 10 years. It's a very small benefit. But when looking across a population, it can impact a very large number of people. But the other side of the coin, the right-handed slide, you start to see a separation in the reverse direction after 6 or 7 years, suggesting that even these people with some comorbidities may have benefited had they been treated more aggressively. There was a very good study done by the medical oncologists showing how poor we are at estimating life expectancy even at the end of life. We can't get, someone's got 3 months, 2 weeks, 5 months, 6 months. They'll say he has 3 months and he'll live a year. They'll say he has 3 months and he'll live a week. I mean, we're not very good at it, and that's why a validated metric is important. Here's all the curves in tandem. The PLCO with no or minimal comorbidity, the Swedish as it is, the complete European contingent. I put those dotted lines in there to kind of show you that in the healthiest men, median age 61, the lowest number needed to treat, the split is the soonest at 6 years. In the Swedish study, it's about 7. In the European study, it's about 10. Pick your flavor. The younger and healthier, the sooner the split, the more likely you are to benefit. But let me make one more caution. The 2 slides on the right are definitive. They're randomized trials. The one on the left is hypothesis generating, but it kind of fits the trend. But just to make sure people understand, the leftmost slide is a hypothesis. So to finish this part, using these data, who should one screen? And I would suggest that probably those who are young and or relatively healthy. I use the word relatively because I'm not so sure that just hypertension alone or colonic polyps is a contraindication to screening. But certainly it would seem to me that somebody who's had CHF, past MI, and is obese is, although further study would need to be done to tease that out. Now, why would young and relatively healthy make sense from a different standpoint? Because the younger you are, the less likely you are to have PSA confounded by BPH, which is the major confounder. And so young men are less likely to harbor BPH, and therefore the PSA has been shown in several studies like Dr. Thompson's PCPT study. Give them finasteride, take out the benign contribution of PSA from BPH. The sensitivity, specificity, ROC characteristics of PSA improve vastly. So that's why young men make sense. And good health is simply a matter of mathematics and statistics. If you're younger and healthier, you have less competing risk, you have longer to live, and more likely to see death from prostate cancer if not aggressively treated, or benefit from a screening test if aggressively treated and found early. Now, this next thing is not published yet, but it was based on a conversation I had with Patrick Walsh last year at the AUA, and this is interesting. Dr. Carroll was there as well during this. We have known for some time that, and it remains unexplained, why prostate cancer mortality was increasing prior to 1993-94. That's that blue line at the top, right? That's the blue line's the African Americans, the pink line is whites, and then we have the other ethnic variants shown below. And then it started to decline. Now, I'm not going to talk about screening. I'm going to talk about surveillance, because this is an interesting study here. Now, look at this next slide. If you look at this, this is 1980 to 1990, at the same time period where prostate cancer mortality in this country was going up in white and African American males. Death from cardiovascular disease, age-adjusted by race and age, was going down, those top 2 lines. And they were going down quite significantly because this is when CABG, coronary care units, the whole field of cardiology, stents, was exploding. Now, is it possible that decreased competing risk from cardiovascular disease, the major killer in men of prostate cancer-bearing age, allowed men to live longer in a time when prostate cancer therapy was not changing to die of the disease? And then as prostate cancer therapy, the radical prostatectomy, the use of hormonal therapy came into play, that started to affect the trend. Now here's a study that we did, again, hypothesis generating, but interesting, about 1,800 men who have a known history of CAD, coronary artery disease, and newly diagnosed prostate cancer treated definitively. A third of them were revascularized for their CAD. 2/3 had CABG, a third had angio or stent, which tells you that, at least at the time when this was done, having CABG as opposed to angio or stent tells you this was significant coronary artery disease. About 70% were not chosen to be revascularized simply because it either wasn't medically possible or they didn't consider it significant. Now, revascularization was associated with a lower risk of death, despite, after adjusting for Charlson score, despite having a higher Charlson score because everyone who was revascularized had a prior history of MI, which buys you 2 points on the Charlson score scale. So revascularization appeared to work in these men. Here's the plot, revascularized in blue, not revascularized in red, and this is all-cause death, significantly different. So the hypothesis would be men with prostate cancer who are successfully revascularized and therefore survive their cardiovascular disease may be at increased risk of dying from prostate cancer. And that may explain why prostate cancer mortality was increasing at a time when cardiovascular medicine was improving. Now, big deal. What does that have to do? Now, you have to have some kind of clinical correlate here. It doesn't, no use to you. So here's 2 more plots and then a conclusion. This is the plot of men who were revascularized, stratified by their prostate cancer Gleason score, 7 or more versus 6 or less. And it's exactly what you'd expect. The 7 or higher, the red line, are more likely to die than the 6 or less. All treated definitively, right? This is the treatment was adjusted. That AHR at the bottom is with treatment, PSA, Gleason, T category, all of that's in account, and Charlson score and age. But when you look at the next slide, this is the interesting one. In the men who were not selected for revascularization, 70% of this cohort, Gleason score is no longer prognostic. That's interesting. Why is that interesting? It's interesting because if Gleason score is no longer prognostic, it means it doesn't make a difference whether they have a 7, 8, 9, or a 6. If they were not candidates for revascularization, their cardiac disease is catching up with them before any prostate cancer that's localized, no matter what the grade, according to this. Now, I haven't done this yet, but if you superimpose these, I don't know if I can go backwards or not. I can. If you look at those lines for a minute, the red and the blue, they max out at 8 years somewhere around 30 and 40%. Now, if you look at them here on the ones that are not revascularized, they max out at 8 years around 50 to 60%. This death on this plot is mostly cardiovascular, and it's doubling the overall death rate compared to those who are revascularized. So what's the clinical correlate here? Most men who have coronary artery disease and newly diagnosed prostate cancer in whom revascularization was not appropriate or was not able to be performed because of medical issues could consider surveillance because their increased risk of death, as I just showed you, was not associated even with high-grade Gleason scores. Now, this, again, is a hypothesis, but it's interesting. I think it's very interesting because it also ties in with the screening story. I would bet that the same people who are on this slide who didn't get revascularized probably shouldn't be screened, and maybe if they are screened and you find an 8, maybe you actually can even watch them. More work needs to be done, but I thought this was very interesting. It started out as a question, why was cancer mortality going up in the early 90s? And then it leads to something else, and for the young ones in the audience, you know, this was not the intent of this particular study. It'll get published a little later this year. The intent was really to explain why cancer mortality was going up. But if you keep your eyes open when you're actually doing a study, what you can actually find is something that you didn't expect, and sometimes it's more valuable than what you looked for to begin with. Now, the next set is things you've probably heard me speak on before. I'll go through it quickly. But PSA, or its derivatives, as a prognostic factor. Here's 2 slides you've seen before. This is Bill Catalona's data. Men with low-risk prostate cancer who underwent radical prostatectomy as part of his screening initiative where he screened people and biopsied after a level of 2.5. If they had low-risk disease and they had a rapid incline in their PSA the year before diagnosis, the red line, they're more likely to die of prostate cancer than the blue line. The same data here for men treated with radiation. And then this slide is new, and this is something that's going to come out in a little bit. We know Jim Easton's study from Memorial Sloan Kettering in JAMA in 2003, which was brilliant, which basically said, if you have a PSA that's over the threshold for biopsy this year, 2.5 or 4, whatever you want to use, what proportion next year will have a PSA that's under the threshold? And they got the bloods from a colonic polyp study where they had blood stored serially. So these are not people who were getting PSAs. They went back retrospectively, looked at the PSA levels, and the numbers are quite fascinating. Right? If you use 2.5, about a quarter of people will be under 2.5 the next year. And if you use 4, almost half the people will be under 4 the next year. It tells you that PSA level, any one PSA level by itself, needs to be repeated before you decide on a biopsy. Because there are confounders. And as well, we don't talk about it that much, but there are plenty of them. Now, we just did a study, which will be published soon, asking the same question with velocity. If somebody comes in with a velocity greater than 2, what we did was we sent them back to their lab where they had the last PSA that made it greater than 2. We educated them about confounders. So we got rid of the assay variation, all these things that you see here, ejaculation, bike riding, horseback riding, infection, blah, 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 all these things. We sent them back to get their PSA repeated, and about 14% of the time, the PSA velocity went from greater than 2 to actually less than 2. And it can start to explain why, when you look at retrospective databases, where education of the patient and the physician is not part of the PSA obtaining process, that velocity and level can be confounded completely. And it can throw away the prognostic significance of a variable unless you get rid of these particular confounders. There was recently a discussion, a paper in JNCI, Dr. Vickers and colleagues, talking about PCPT and PSA cut points and PSA velocity. And I think that one has to recognize that while the PCPT is an enormous effort and a great study, I don't know that every patient who got a PSA each year on that study was educated about assay variation and all the things that can confound PSA, making change in PSA evaluations in that study difficult to interpret. So I think you need to eliminate confounders before using PSA to recommend biopsy or treatment. So these are the risk groups as we've seen them before. I put PSA velocity greater than 2 into the high-risk category. And here's a whole series of slides, data. This is Duke data that says that when you have multiple determinants of intermediate risk, or for that matter, high risk, your risk of dying goes up. The red line, you have all 4 factors, the blue line, 3. This is surgical data. Here's external beam radiation data, the same pattern. Here's radiation and hormonal therapy data. We grouped 3 and 4 factors versus 1 and 2, same pattern. And this is not published yet, but one of our residents put this together, Dan Watson, where for brachytherapy, because this hasn't been looked at in brachytherapy. If you have multiple determinants of risk, do you have increased risk of cancer death? And in fact, you do. Same thing for external beam and brachytherapy, and the same thing for external beam hormonal therapy and brachytherapy. It's all common sense that the more determinants of risk you have, for example, a guy who's a 7, but his PSA is 4 and he's a T1C is a lot different than a guy who's 7, who's a T2B, and who's got a PSA of 15. The more acquisition of determinants that you have of risk, the worse you do given a specific therapy. And that just speaks to the fact that we know very well how to predict outcome, but we have to think more intelligently how to deliver treatment. You know, one thing I will show you, though, is that if you go back, look at the brachytherapy alone, red line, up about 15% at 8 years. And over here, when you have external beam and brachy at 8 years, you're at about 12%. When you give all 3 treatments at 8 years, you're about 8%. Now, that's not fair to do, except what I'm trying to get at here is that maybe a guy who has all 3 factors should be thought about having combined modality therapy than unomodality therapy. It's kind of the back door of what I'm trying to get at here is pick the right treatment for the right patient. Don't treat everybody the same way. Counsel them differently. If you've got a guy you're going to take to surgery with 3 intermediate risk factors, talk about he may need adjuvant, whatever, down the road, or his PSA may rise and he may need salvage at that time. I find that education up front is the best medicine because what it does is it prepares people for what might come, and then they're willing to work with you, interestingly. All right, so what this basically, this is sort of the mathematical side of it, is that we increase the risk of death with more determinants of risk. So from now on, when we do a prospective study or when we do a retrospective look and we do a regression model, we should not just be adjusting for risk group or just PSA level or Gleason score. One might consider also adjusting for the number of determinants of risk. If you're doing a study with intermediate risk patients, you may want a pre-randomization stratification by do they have 1 of these, 2 of these, or 3 of these risk factors, because clearly it appears to impact on the rate of cancer death following a specific treatment. The last piece about prognostication is this one. You've heard this before probably as well. Tertiary grade 5, an otherwise Gleason score 7 patient, has them behave more like an 8 to 10. This is Abhi Patel's work. It was in JAMA a few years back. The blue curve are 7s with grade 5, and that's PSA recurrence. The red curve is 8 to 10. The black curve is 7s without grade 5. Bottom line is if you've got tertiary grade 5 on the biopsy, they behave more like 8 to 10s. No surprise, but this is something that should be incorporated. The 7 with grade 5 is high risk, not intermediate. And that's the summary of everything I've just said here in terms of risk group stratification, with the intermediate risk caveat of more than 1 factor in intermediate risks makes you high risk. And Dr. Carroll has shown this and others, that when you have more than half the cores positive in a low-risk patient, i.e. a high-volume, low-risk patient, they behave more like intermediate risk. And what I've seen is you'll take them to surgery, and oftentimes they're the ones who have unsuspected upgrading or positive margins. And so it might be worth counseling them if they're a high-volume 6. Often a high-volume 6 just means there's grade 4 that's been missed. Last topic is the management of a rising PSA following surgery or radiation. And what I'd like to give you here is some practical approach to this particular patient. There have been multiple studies that have shown that the rate of rise of PSA in this setting is important. If it's rising very quickly, people may get radiation and respond, but only for a short time and not as long. If you give them hormonal therapy, they may respond for a long time, but ultimately often succumb to their disease if, in fact, the doubling time is very short, like less than 3 months or less than 6 months. If it's very long doubling time, sometimes you can get away without treating them at all post-operatively, live a long time without any issue. And certainly you wouldn't give them hormonal therapy. You might consider radiation down the road. So there was a study in JAMA by Bruce Trock from Hopkins a couple of years ago now, retrospective series, looking at an association between whether salvage radiation is given at the time of rising PSA post-op versus observation. And he showed that if you do the treatment within 2 years of PSA failure, that is PSA greater than 0.2 in his study, despite the doubling time being short, less than 6 months, that you saw a longer survival. Now, this is hypothesis generating because it's retrospective, but it's interesting because I would not have expected the short doubling times to benefit from radiation alone, in fact. What about the patients with long PSA doubling times? What about the role of hormonal therapy? We're going to address both of those in the next 2 minutes. The median follow-up in this study was 6 years, and Dr. Trock made it clear at the AUA presentation and in the paper that that's too short to see any potential benefit in men with longer doubling times because the median survival of somebody with a doubling time less than 6 months is about 9 years after PSA failure. The median survival of somebody with a doubling time of 15 months has not been reached at 15 years after PSA failure. And so with a 6-year median follow-up, you'll never have enough events in a long doubling time group to see any difference until this study, which was done in conjunction with Dr. Mall at Duke and one of our chief residents, Shane Cotter, looked at 4,000 men, 519 had PSA failure, median follow-up 11.3 years as opposed to 6 years. And when he does the adjusted analysis, adjusting for age at the time of PSA failure, Gleason, T category margin status, and hormonal therapy use, he finds a reduction in mortality, whether the doubling time is less than 6 months, hazard ratio 0.53, or greater than or equal to 6 months, hazard ratio 0.52. And I know Dr. Klotz is in the audience, so I want to be clear that, yes, the reduction is the same in both groups, given enough follow-up time to visualize and see it, enough events. But if you ask, how many people do I need to treat in order to benefit a guy with a doubling time of 12 months versus 6 months, the answer is 3 times more, because there are much fewer, if you will, events, and it takes a whole lot longer to see the benefit. Now, this is true. And if we're talking about healthcare reform and cost containment, you might just treat the worst players. However, I'd like to beg that we just take a more intelligent look, which is, are there people with long doubling times we should treat? Example, someone who had a prostatectomy 2 years ago, right, at a 3+4 focally positive margin, T2B, right, who now is, in excellent health, and he's 51. His PSA is rising, 52, 53. It's rising very slowly. This is the guy I treat because he's in excellent health, young man. But if I take a person, who's had radiation in his 70s, who has the same kind of rise, who has comorbidities, and a very long doubling time, we don't treat him. We don't salvage him necessarily because it's unlikely he will benefit. So what I want to show here is that it suggests, because it's a retrospective study, doesn't prove, that no matter what the doubling time, radiation can be beneficial given long enough follow-up, meaning healthy patients, right, living a long time. That median follow-up's 11.3 years before you see that benefit in a long doubling time group. We tried to look at this by comorbidity, and I'll caveat it. We only saw benefits in the low comorbidity group. The significant comorbidity group, though, had limited power. This was a surgical database selecting healthy people. The number of people with CAD, CHF, and MI were very small. Look at the 95% confidence interval and adjusted hazard ratio. It goes from here to California, right, 0.21 to 15.46. So it's very limited in power. Same thing on the slide with the less than 6 month group. So I can't make comments on which comorbidities you should exclude or not. Probably somebody who cannot be revascularized, right, from what I showed you earlier, who has known coronary artery disease is a good one to hang your hat on. But other than that, we can't be more specific. So to conclude, the shortest doubling times are men who already are resistant at least to the standard forms of hormonal therapy. Whether abiraterone will fit and change that or not, potentially it will. It should be looked at, and it probably can be based on the data we have right now. Long doubling times post-surgery should be considered for radiation if they're young and healthy. If they're post-radiation and they're still young and healthy, the salvage therapies that need to be looked at, I say, should be looked at on study, whether it be prostatectomy, cryo, HIFU, or brachy, because they're morbid. In the middle group, there are a number of questions that remain to be answered, but there's a randomized trial that was just reported the end of last year by Bill Shipley at Astro, looking at radiation with or without hormonal therapy in the setting of a rising PSA. And while it's not ready for prime time yet, because it just showed a decrease in distant failure, which you'd expect from the use of hormonal therapy, it certainly is promising. And should that show a cancer-specific survival benefit down the road, we will have a lot more to say in terms of how to manage these people. Currently, what I do is if a guy is an 8, 9, or 10, or if he had SV involvement, or if he had positive nodes, clearly the last one we have data for, but the first two are inference, I do add hormonal therapy. The question is how long, and how much, and to what extent. Tomorrow, I'll talk about hormonal therapy in the radiation section. So the last slide, the rising PSA cohort is, like everything else in prostate cancer or in medicine, heterogeneous. Do not do one size fits all. Think about the individual in front of you. The appropriate treatment depends upon their health, in addition to their prostate cancer kinetics. If they've got the young guy, I'm more willing to treat even a long doubling time. An older gentleman less healthy, I'm even less willing to treat a short doubling time. But I think that the take-home message here, as I've tried to give you, is in the context of screening, surveillance, and treatment. Comorbidity matters, and using common sense in terms of who may or may not be appropriate matters too. So thanks for your attention.